Hello, Thrive Nation. I've got two incredible books that are going to be released on April 12th by two amazing people. And I'm so fortunate to have read these books. What an eye-opener. And being a physician in my other life, everybody knows that gut health has become such a huge issue locally in South Africa, Africa, and beyond. And I've got Dr. Ali Rezaie, a gastroenterologist with so many credentials. We're going to put it in the show notes, but this man is a pure genius. He's written and co-authored over 100 peer-reviewed scientific articles, as well as been cited over 6,000 times. We've got a huge health hero in our midst. It's a privilege to have him. And then together with a Good Life cookbook, Krystyna Hauser, we are going to get their backstories and we're going to hear in terms of their journey. But I do want to hear from Dr. Ali. Why did you write the Microbiome Connection?
First off, thank you for having me, and thank you for those kind words. Pleasure to be here. So the big question was that going back to patients suffering with GI health with a lot of symptoms that we're going to go into detail. Patients that we generally put under the umbrella of irritable bowel syndrome. If you look at the definition, essentially it says, well, if you have abdominal pain and change in bowel habits for 3 to 6 months and beyond that, then you have irritable bowel syndrome, and then you get treated with very generic treatments as of 20 years ago. 40 years ago, this was even considered a psychosomatic disease, meaning that, hey, this is all essentially in your head. We can't find any ulcers, we can't find any abnormalities in your gut, so it must be in your head, which is actually not an unusual thing in medicine, as you know better than me, that whenever we don't find a specific biomarker or a specific organic visible abnormality, then we just say that, well, it has to be psychosomatic, because, you know, in medicine, all physicians, including me, we are a little bit of an egomaniac, and we don't want to say that I don't know. We just say that, well, yeah, it's in the head. And there are multiple diseases are like that. Considered like conversion disorder is one example that people thought it's psychosomatic. Eventually turned out that some of these patients are MS. So patients with irritable bowel syndrome have multiple organic abnormalities, as it turned out in 90s and 2000s and 2010. We have a lot of research that has been done, and we were fortunate to be part of it. And that main part that we want to focus today is the changes that are happening in the microbiome of patients. And here we are in 2022 for presumably a psychosomatic disease that was considered to be 40 years ago, an FDA approved non-absorbable antibiotic for treatment of irritable bowel syndrome in 2022, which was actually approved in 2015, which is a revolutionary switch that was happening in this field. And that is because of discovery of the Microbiome Connection and the association of Sibo, small intestinal bacterial overgrowth, that hopefully we can go into more detail about that, with irritable bowel syndrome, that leads to helping patients to get help without saying that, well, it's in your head, here's your antipsychotic and antidepressants, and go and move on. So I think that was the key moment for us to move into this direction and trying to help.
So there were no other books on the market in terms of just pressing you that you could give to patients that had the research, that had the backing, had the information. Is that why you saw a gap, or did you decide, listen, let me look at the last scientific sort of meta-analyses and look at the research, and let's present a book that people that are suffering or family members can read to help those sufferers and sort of break the dogma of something like this? It's it's all in your head, it's psychosomatic. So is that why you wrote the book?
Yeah, so to be fair, this is not the first one. This is actually the second one. The first one actually was written by my mentor, Dr. Mark Pimentel, who we co-authored this book several years ago. At that time, that book was faced a lot of resistance. You know, whenever you come out with a trailblazing idea, that kind of gets resistance from a traditionalist. But this book, essentially, after providing that idea and doing numerous research, and now we have an FDA-approved drug through that pathway. Now we have put all the updates on top of that to see what the research is ongoing. And another step that we have in this book is to how to manage it over long term, i.e. through low fermentation eating. And that was a fruitful collaboration that we had with Krystyna and also our dietitian, Robin Berlin, because this would not have happened without collaboration of a patient who is very willing to help herself, a dietitian to change the life, do the lifestyle modifications and diet, and the physicians as a group to come up with that plan to push it forward, understanding that, okay, from my standpoint, this is working. From the dietitian standpoint, this is working. And more importantly, from a patient standpoint, this is working and doable. So many times, physicians, we just said, well, do this, do that. But patients said, well, easier said than done. I can't do that. But that was the key in this book that we put forward.
Brilliant. And let's go to you, Krystyna. What a great cookbook. And tell us your sort of maybe a short backstory on why did you write this book?
Robin and I wrote the book, purely out of necessity and inspiration. I know that Robin has dealt with Sibo as well. So she was the perfect dietitian to collaborate with. But from my perspective, it was a way to keep myself focused on the diet. So selfishly, it was for me and to help figure out how I could still live a normal life. Developing recipes that my children enjoyed, that my husband enjoyed, my friends and family were really important to me. I didn't want to be that person that walks into a restaurant with a massive pamphlet or not have dinner parties or make myself special meals. I didn't want to bring attention to it. So I was determined to figure out a way to bridge the gap and make everyone happy. And I think that we accomplished it.
Brilliant. So from pain to purpose, you were a sufferer, you were a Sibo sufferer, you were an IBS sufferer, or you're an IBD sufferer. What is your sort of short backstory?
It's not particularly short. It's a bit of a health odyssey. About now 7 years ago, I gave birth to my third baby. And that brought on all sorts of complications, as many mothers understand. And I had to take incredibly strong antibiotics, which just knocked my system out of whack. And it took 2 years of seeing GI doctors in Manhattan to be told that I'm insane. I probably have postpartum depression. It's all in my head. And to pretty much stop bothering them with this. And of course, Dr. Ali knows I'm quite persistent and don't take no for an answer, and knew something was wrong and kept digging and trying to figure it out. And finally, a friend of mine suggested that I see a Western Eastern doctor in the city called Dr. Frank Lipman. And Frank took one look at my eyes and my tongue and said, "You have Sibo," and told me to go to my GP and get tested using a breath test, which is relatively easy and convenient. And I did, and I had it. And so my GP said, well, if you do have Sibo, you should only see Dr. Mark Pimentel or Ali Rezaie. There's no other option. Nobody else knows more about it than these two guys. And luckily work brought me to Los Angeles and I was able to meet Ali, and that's where it started. But when we met, I was determined not to take antibiotics, even though that's one of the quickest and easiest things to do to treat Sibo, at least in its onset, because of maybe it was an emotional trigger to those horrible antibiotics I had to take after the birth of my of my child. And Dr. Ali was quite patient with me. We went down this pseudo holistic path where I went on an elemental diet. I took herbal antibiotics under his guidance. Then I somehow was convinced to take other medications, and he was right. So I do think that it is a combination of listening to your body, Eastern, Western approaches, and ultimately finding a doctor you trust. But really, it's self-advocacy. You know, if I didn't push forward and figure out what was wrong with me, I'd be malnourished right now. When Dr. Ali diagnosed me with Sibo and I had my blood taken, on paper, I was the healthiest person you could imagine. Green juices, and, you know, I was borderline vegan and doing everything I thought was right. But my blood work showed that I was malnourished because my intestine was not able to absorb the nutrients. So, you know, Sibo might seem like it's not such a big deal, but I think long-term disease and lack of diagnosis can really add to more serious complications.
Yeah, what a story. I get emotional that you realized and took accountability of your own health. I think of Hippocrates. We say this: the greatest medicine of all, we say this at Made to Thrive, and in my practice, is to teach people how not to need it. And yet you went to doctor upon doctor, you carried on persisting. Dr. Frank Lipman's been on the show. He's a South African international hero. So what a story of hope to many people that are really struggling in this area. And being in practice in my other life for 23 years, we've just seen more and more gut issues again and again. From the toxicity, we had Dr. Stephanie Seneff, who's a glyphosate specialist on the show as well, telling us what glyphosate's doing to our guts and our GI tract. So it's very prevalent and it's becoming more of an issue. Dr. Ali, let's give us a little bit of your academic credentials, because I think that's important. We want to promote the book. I know it's not a short description because you're so accomplished, but a little bit of a backstory in terms of where your practice is, your clinic is, and just the empirical evidence. I know people out there, and I want to give us sort of a patient sort of picture and profile so people can relate to it straight away. But just where you are, what you're doing, and what about the future for Dr. Ali?
Yeah, so I'm an associate professor at UCLA and also Cedars-Sinai Hospital in Los Angeles. And in terms of clinical work, I'm the director of GI Motility Program. So GI Motility program deals with GI disorders that affect the motility and also microbiome. Motility of the gut and microbiome go hand in hand. So these two usually are coming together in multiple diseases. And there, obviously, I see up to 100 to 150 Sibo patients per month. Having said that, there are so many patients out there. I mean, that's just a drop in the bucket. And that was one of the reasons that we wanted to write the book, because if you look at the numbers, between 15 to 35 million people in the US alone have irritable bowel syndrome. And about 60 to 70% of those do have a bacterial overgrowth of Sibo. So if you think about it, there's 20 million people with Sibo just in the US. So that's why we wanted something for those who can't see to be helped with, both from the lifestyle modification and both from the understanding the pathophysiology to help them. From the research standpoint, we do have a program at Cedars-Sinai called MAST, Medically Associated Science and Technology. And essentially, we only focus on gut microbiome. This is a team of 30 postdocs, nurses, research assistants, and with Dr. Pimentel and Dr. Richard Mathur, that's all together, we only focus on the role of gut microbiome and health. And one of the main focuses that we have is obviously the small intestinal bacterial overgrowth, developing new therapies, developing new diagnostics, and also developing new discoveries. Oh, okay, what needs to be done and what needs to be helped. Also, we do have a device development to help with the microbiome, whether through internal UV therapy or through devices that diagnose things to improve, for example, endoscopic aspiration of the small bowel. So those are the two hats that I wear, the clinical part and also the research part too. And the beauty of it is that I'm lucky that both arms feed each other. I see the problem in the clinic and I take it to the lab to see if I can help patients back, and I take that help back and check it to see if it's helping. If it helps, well, good, great. If it's not, well, like, oops, what went wrong, right? So, you know, the beauty of research that we do. And so on average, we have 40 to 50 active research projects together, and some of them are with Krystyna. So that's very fruitful, and I like that field. That's the way that we're working. And I mean, I have to say that with the help of the patients, without the help of the donors and very committed patients and entrepreneurs like Krystyna, these programs like what we have can't move on, and that has been the gas for this fast rolling engine. So that's kind of, sorry, I went too long, but that's essentially what I do on a general basis.
Fantastic. And what a combination of entrepreneurs that have gone from pain to purpose. They have now partners with doctors, physicians that are practically seeing patients, getting this empirical evidence, as well as being in the research at UCLA. Well done, guys. What a privilege, what an honor to have people that want to see people's lives transformed. And I think that's fundamentally important in this crazy, chaotic world that has sort of, had another level of stress. We'll talk about stress, this dysautonomia and what's happening with the vagus nerve. I'd love to get your, perspective on the vagal tone and how it affects, Sibo and IBS. But let's take a rundown, Dr. Ali. You speak of IBS-C and you speak of IBS-D and you speak of IBS-M and all these acronyms and IBD and you speak of Sibo. I want you to just picture a patient now who's had chronic bowel dysfunction. They've struggled with their stomach. They've had constipation, diarrhea. They've been to their doctor. They've tried. Other than what I'm going to start doing is recommending the two books, because one is about knowledge and empowering people, and then giving them the tools of Krystyna and this incredible book. You're helping patients practically. There's no point giving them the knowledge, giving them the information, then what do they do on a daily basis? So give us a rundown of all these acronyms, what they are. And now we've got a picture of a patient. Let's call her Mary. And Mary's been struggling for a very, very long time. She's seen many physicians. What does she do? Where does she go?
All right. So let's describe what Mary looks like. So let's say Mary is in her 40s and she was all good 5 years ago. She was having one bowel movement a day. She was working like normal, like 8 hours a day, having a very active social life and enjoying her life. She picks up food poisoning, just like any of us get it. So when we travel a lot, like she didn't make much of a thinking about it. And then about 6 months after that, she started to notice that her bowels have changed. Now, instead of one bowel movement every day, she's having 2 or 3 bowel movements a day. And what she notices is that as she wakes up in the morning, her belly is flat. But then as the day goes along, after she eats, the belly gets more and more bloated and distended. And by the evening, she can't even wear her usual pants. And she feels like she's almost 6 months pregnant. That is affecting her quality of life. She can't go out. She can't eat. She feels full. And that is associated with some excessive amount of belching, excessive amount of flatulence. And now bowel movements get worse and worse. Now they're getting to 4 or 5 bowel movements a day. And interesting enough, some days she has no bowel movement at all. She feels urgency, meaning that now instead of just having a good like an hour or so to get to the bathroom, if she has to go, she has to run, and that's something we call bowel urgency, which is very common in patients. This is to a point that she has to download an app on her phone to tell her where is the closest bathroom. Which is very common. If you look at the app stores, there are these apps that have been downloaded millions of times just to tell you where is the closest bathroom, because patients have so much urgency. Sometimes she even loses control of the bowel, and that is called fecal incontinence. And that's something that she hasn't even brought up with the doctor, and that's because of the excessive amount of diarrhea. Now, this amount of bloating and distension is leading to abdominal discomfort for her and even abdominal pain. She feels even nauseous. She doesn't feel like eating her usual food, because she notices that whenever she eats food that specifically have a lot of sugar and carbohydrate, she feels very, very sick. So that's a classic story of patients with irritable bowel syndrome that we hear. Now, if you're more on the diarrhea side, meaning that you're having loose and watery bowel movements, we call it IBS diarrhea. If you're more on the constipation side, meaning that you have a lot of straining, you have very hard stools, you have issues with evacuation, we call it IBS-C. And if you're in the middle, that you have both of them and you constantly alternate between these two scenarios, you're called IBS mix or alternating bowel syndrome. Now, a lot of patients with this scenario, especially the ones who have had post-infectious irritable bowel syndrome, whenever we pick up food poisoning, by the way, 11% of us go ahead and develop post-infectious irritable bowel syndrome, which, if you think about it, how common is food poisoning, that's a mind-boggling number. So millions of people suffer from food poisoning every year. So maybe we should step back and talk about a little bit of basics of relevant story to microbiome and Sibo. In our mouth, we have a lot of bacteria. We have 10 to the 9 bacteria per ml, essentially 1 billion bacteria per ml. In our colon, we have 10 to the 12 bacteria in our colon, meaning that 1,000 billion or 1 trillion bacteria per ml. But interesting enough, in the small bowel is all of a sudden less than 1,000 bacteria per ml. So between two, quote unquote, dirty places of mouth and the colon, small bowel is maintaining relative sterility. If you think about it, that's amazing because small bowel doesn't have antibiotics. So how does it do it? It does it through housekeeper waves or migrating motor complex phase 3. So what are those? Whenever we eat, the food goes into the stomach and sits in the fundus of the stomach and slowly gets fed into the body of the stomach. And then stomach starts to produce acid, triturates the food, and breaks it down to 1 millimeter pieces. And that goes towards the pylorus, which is the sphincter that connects the stomach into the small bowel. And if those pieces are that small, then pylorus allows it to go through the small bowel. That's when the feeding phase ends and the fasting phase starts. And the fasting phase of the small bowel has 3 phases, essentially 3 stages. Stage 1, that the small bowel waits for this mixture of food and acid, which is now called chyme, to get mixed with bicarbonates from pancreas to neutralize the acidity, and also gets mixed with the enzyme. Phase 2 is non-propagating contractions of the small bowel that mixes the food with the enzymes, get it closer to the villi of the small bowel so they can get absorbed. And that is the longest phase of the small bowel. But the most important wave of the small bowel are called housekeeper waves. So every 90 to 120 minutes, a wave starts from the antrum, which is the end of the stomach, or the beginning of the small bowel, which is called duodenum, and sweeps through the whole small bowel, the whole 20 feet of small bowel, and dumps everything, including residual food, residual bacteria, and also residual enzymes into the colon. This wave only lasts 5 to 8 minutes in each segment of the small bowel, and after that, it goes back to phase 1. So these waves, if they're not there, then you start to have abdominal cramping, abdominal sort of pain, and also you can get diarrhea, or even you can get a constipation. Why is it relevant to Sibo? The bacteria in the colon, bacteria are smart. These are living organisms. They're just sitting in the colon, literally eating stool, but they're saying that, well, fresh food is up there. So on a constant basis, they like to creep back into the small bowel through the IC valve into the small bowel for a search of fresh food and more nutrients. But migrating motor complexes say that, no, go back where you are. And they push them back into the colon.
Yeah.
And that's how small bowel keeps itself with bacteria less than 1,000 per ml. Now, if these waves are affected, then the bacteria in the colon come back into the small bowel. And when you eat, some of the food you digest, but some of the food now are being digested by the small bowel bacteria that are now multiplying in excess because they are not being kicked out. Then they produce a lot of different things, including gas. Bacteria produce a lot of gas, they ferment things. We take it for granted when we're fermenting food, but sometimes it's a bad thing. So they produce hydrogen, they produce carbon dioxide, they produce hydrogen sulfide, they produce methane, and all those gases make the small bowel like a party balloon. The problem is that small bowel is not skilled to push gas forward. It's skilled to push liquid and solid forward, but not gas, because it's our colon that is skilled to push gas forward, and we all know that. But the small bowel doesn't know what to do with gas, because it pushes things like milks forward about a foot, but then it lets go. But liquid and solids moves forward, but gas comes back. So that's why a lot of patients with Sibo said, hey, I feel like gas is trapped in me. I can't belch it out. I can't pass it as gas. And that is a big problem in Sibo patients because it's in the small bowel. So this gas has to sit there, causes a lot of problem, and then it dissipates into the bloodstream and we breathe it out. And that's why overnight we feel the best, because this gas has been exhaled all throughout. And that's actually the basis of breath testing, that we pick up hydrogen and methane that is exclusively produced by gut bacteria in the breath testing to diagnose Sibo. And that was the test that Krystyna was talking about. Now, what causes this motility? 1,000 different things that causes this motility. One of the main causes, I just named it already, and that's food poisoning. Food poisoning through multiple pathways that we have now discovered several years ago. For example, through autoimmunity. These antibodies that discovered anti-vinculin and anti-CDTB, they attack the gut and they don't allow it to contract, that they mess up the migrating motor complexes. So that's the cause. But it can be because of surgeries, it can be because of medications, it can be because of diverticulum, outpouching in the small bowel. And I mean, there's at least 100 sort of different causes that I can mention for you. So now this excessive amount of bacteria in the small bowel leads to all these sorts of symptoms because of gas production, or even side products that it can produce, that more and more we're understanding, including serotonin that can cause diarrhea, including some compounds that we don't know what they are, but they can even cause brain fog. So the key now that we can go into the treatments of this is to suppress the bacteria and also improve the motility of the gut to keep the bacteria in the small bowel suppressed. And that's where the low fermentation eating comes into play. Sorry, that was probably the longest answer to your question, but I just wanted to make it clear where Sibo sits and where IBS sits, and the big overlap that happens between the two.
Brilliant. I think that was well summarized in a very short time in a very complex condition that probably could have multiple days of conferencing on. So thank you for that. But let's talk about assessment, because there are these devices people can, buy off the internet and produce, and a result with regards to whether they've got Sibo or not, and also RBS, the blood test that can be done. I think if Mary is struggling out there and she's hearing this, and does she need to go to a gastroenterologist to do the test? Are these other little devices that are on the internet, are they pretty good? Do they help patients to see where they stand? Is there a trend? They might not be accurate, but they might be precise in terms of the trend that maybe they give a measure of 7, and then 3 days later, or with all the diet lifestyle plan plus the Good Life cookbook, all of a sudden it's down to 3. Give us your sort of overview on assessment.
Okay. So just quickly, how do we diagnose small intestinal bacterial overgrowth? There are essentially 2 fundamental ways. Number 1 is to do an endoscopy, go into the small bowel and aspirate the small bowel content, and to grow that to see what type of bacteria is growing and what type of even fungi is growing, or concept of small intestinal fungal overgrowth. So, issues with that is that, it's an invasive test. Number 2, when you're aspirating the small bowel, you can't aspirate the whole 20 feet of it. So you're aspirating a segment of it. So there is sampling error to it. And also, we can't culture every bacteria that are out there. There is no exact estimate, but about 30 to 40% of the bacteria that we can culture out there. And another issue is that archaea, which are older than bacteria, and they can produce methane and cause constipation, that can't be cultured on regular labs. So it has those limitations. The other option is to do breath test. Breath testing is actually, we published through American College of Gastroenterology 2 manuscripts, one of them that summarizes through a North American consensus that how to do it and what is the best way to prepare for it, interpret it, and to be done using sugars. So you have to standardize the test, because otherwise the numbers are hard to understand. So we give patients after fasting sugar, we give glucose or lactulose, and this sugar goes into the small bowel, starts to get fermented by the small bowel bacteria, produces gas, hydrogen and methane mainly, and also hydrogen sulfide. And then that comes back into the breath and we measure it, right? So hydrogen and methane in the breath are exclusively produced by gut bacteria. Our cells are incapable of producing hydrogen and methane. So that when we pick it up, that's only from gut bacteria and nothing else. So we kind of trend it over 2 hours. Every 15 minutes, we do a breath test, and we trend hydrogen and methane levels to see if they rise or not. The cutoffs are not important, but for this talk, but if it's hydrogen rises by more than 20 parts per million within the first 90 minutes, that means that there is excessive amount of hydrogen producing bacteria. Or if there is a methane level of more than 10 parts per million, then that means that you have excessive amount of methane producing archaea. So, and that diagnoses you with the bacterial overgrowth. So now you have diagnosed yourself with this, that at least we know these are the ways that are standardized for clinical practice. Now there are new ways that are coming, all the research, right? We deep sequence the small bowel microbiome. We even shotgun analysis of the small bowel to see what exactly are the bacteria that are not culturable or in there. Those are still in the research realm, and it's still not applicable for clinical practice, but hopefully there will be some tests associated with them coming along. So those are the 2 tests that I recommend, because now we have treatments that have been shown to be associated with improvement of symptoms based on this test, and also monitoring the treatment is also important, that can be done with these tests. So those are the 2 main tests that I recommend in terms of diagnosis.
So not someone getting a device off the internet and trying that and testing it and possibly reading your book. Is that not something that you would advocate?
I won't advocate that for any medical diseases. So yes, being self-aware of what you have, reading about it is important. But I mean, no matter what disease you're dealing with, I think having a healthcare provider on your side is very important. As you can see it, right? So the false news on internet is even like BBC and CNN are having a hard time teasing through it to see what's real or not. So you have to leverage the expertise of somebody that knows what he's doing to make sure that you're not going the wrong path. So you need your functional doctor, integrative doctor, or like Western medicine doctor who's familiar with bacterial overgrowth to help you out. Otherwise, there's so much data out there that I guarantee that you will be lost. I'll give you an example of it for myself. I had some joint issues recently, and I went online. I'm like, I can't figure this out. I'm a doctor. I can't figure it out. I need help. So I went to a rheumatologist for help. I was like, okay, I'm so confused. I don't know what to do with this. So it's the field of medicine has grown so much, and teasing out good and bad and also sort of the gray zone sort of data, it's really, really hard. So you need the help of a healthcare professionals like you to help patients. So that's what I recommend for sure.
Sure, and I understand that. And I think the Good Life Cookbook, I think, is something that someone could possibly pick up if that could be helpful, even if they can't. In Africa, we've got affordability issues. It's sometimes difficult for people to see practitioners the whole time and get these tests regularly, see where they are, track the progress by re-auditing. So that's why I ask, and I think the way of the future, and maybe possibly the technology will get better. And if we talk in a few years' time, you'll say, yes, the things that people are taking on, checking their, blood pressure. I mean, you talk about 100 years ago, the average person now can check their blood pressure at home. They can check their glucose at home. So it is, we do want to, the chasm between the specialist and the cost of the specialist. We work with a lot of health coaches. Maybe that could be even adequate. Just someone to guide, someone to help, someone to talk about, the dietary, look at about the cookbook, what works, what doesn't work. But I think we just know, especially in Africa and beyond, that we don't have enough doctors that are educated. And that's why I'm so excited about this Microbiome Connection and the Good Life Cookbook, because I think it's going to help a lot of practitioners. It's going to help a lot of doctors. It's going to help a lot of specialists. I think your dietary advice at the end of the book and the Good Life Cookbook, it was quite surprising to me in many ways. And I've been dealing with a lot of gut patients for many, 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 many years. So maybe just a quick, the diagnosis and testing of IBS, because there's a lot of crossover, but some things are going to, be beneficial to an IBS patient and harmful to a Sibo patient. How do we diagnose IBS now?
Okay, so the diagnosis of IBS, the limitations that we have right now is that the main definition is completely subjective, right? So it's based on symptoms, abdominal pain and change in bowel habits. So the problem with that is that, well, think about it. How many diseases can lead to a combination of abdominal pain and change bowel habits? Numerous, right? So Sibo, we talked about, small intestinal fungal overgrowth, we talked about, food sensitivities, food allergies, carbohydrate malabsorption, such as lactose intolerance or fructose intolerance can lead to that. Intra-abdominal adhesions, all those diseases can present the same way. And that's the problem with IBS. So you can't possibly come up with a single test that diagnoses all IBS patients. That's just not a problem, and not a possibility. So that's why in clinical practice, unfortunately, this led to a diagnosis of exclusion. What does that mean? That means that people will try to exclude everything that they can. At the end, they can't figure it out. They call it IBS, which it got a bad rap to IBS because, well, it's when you can't find anything. So there are blood tests that are coming out. Multiple groups are working on it, including us. That what we found is that with patients who have post-infectious irritable bowel syndrome, when, for example, you get Campylobacter, you get infected with Campylobacter, and that causes diarrhea. That's the most common cause of infectious gastroenteritis in the US. In other countries are E. coli. And they all have a protein called cytolethal distending toxin. The name is not important. I call it CDTB from now on. Just like any infection, when you get that infection, you develop antibodies, and those antibodies are called anti-CDTB. The problem with anti-CDTB is that it takes another protein in our body called vinculin as its point of attack. So there is molecular mimicry there. And it attacks another protein, and we start to develop anti-vinculin, and that anti-vinculin is an autoantibody. When we produce antibodies against a protein inside our bodies, it's called autoantibodies. So these autoantibodies attack the vinculin on a constant basis, even though that Campylobacter is long gone. Now it's you get into this perpetuated autoimmunity after an infection, and this autoimmunity against vinculin. The problem is that vinculin is essential in the work of enteric nervous system, the nerves that helps the bowel. So when the nerves of the bowel are not working, then the migrating motor complexes won't work. When the migrating motor complexes are not working, then you get Sibo and you get abnormal microbiome. So this whole pathway propagates and leads to bacterial overgrowth. Now, the good news is that now you can check those antibodies in your blood. So anti-CDTB and anti-vinculin, and right away, you know that, yes, you have post-infectious IBS. Brilliant. But remember, that's not the only part of IBS. So this essentially tells you, yes, this is what you have. So if it's negative, doesn't mean that you don't have IBS.
Yeah, sure.
But this is actually very nice, because that shows that where the field is going to find objective testing to treat patients, and then hopefully tailor to treatment based on that. So that's one example of how we're diagnosing what needs to be done. Yeah.
So let's go to you, Krystyna. I think, someone's been diagnosed, they've been to their functional medicine doctor, the gastroenterologist, they've got the diagnosis. Now I'm going to recommend your cookbook. Tell us about the low fermentation diet and what the pillars are to this low fermentation diet.
So as Dr. Ali explained, the most important thing to do when you're a Sibo patient is to promote the waves and to keep fermentation low in your small intestine. And the diet promotes that. The diet will not harm anyone who has IBS or Sibo. And so what I love about it is it's a good blanket diet. And correct me if I'm wrong, Ali, but so no one will be harmed apart from a celiac patient who should not be cooking from the book, because we do use flour. I found that diet was the number one thing that helped me. I no longer have Sibo. The condition is almost, not impossible to cure, but very difficult. And I really do credit low fermentation eating for that. And maintenance is so important, even after you see a doctor and go on antibiotics, herbal, or whatever medications you and your physician decide are the best for you. Maintenance afterwards is the most important. Most patients who get better then get worse again, or are on this perpetual roller coaster. So low fermentation eating, I cannot recommend enough. But having said that, I no longer eat that way. I can eat anything I want. Beans, cruciferous vegetables, it's all on the table for me. We're really proud of this book because, Ali, you can attest to this. Our number one goal was to not harm any digestive issue.
Fantastic. Maybe go through the macronutrients. We know that mostly it's low carbohydrates, but there are some very specific carbohydrates that people should avoid. So between your carbohydrates, what should people avoid? Proteins, what should they avoid? And fats, what should they avoid?
The number one thing to avoid when you have Sibo are fermented foods, because they add to the growth of bacteria in your small intestine. So decreasing cruciferous vegetables, legumes, there are a lot of proteins and easily digestible fruits and vegetables on the diet. The diet also has proven to be beneficial in long-term Sibo SIBO health and maintenance as opposed to the low FODMAP diet, which is the low FODMAP diet is more beneficial in acute situations and short-term use, whereas low fermentation eating can be used for years, and people won't suffer from malnutrition as they would with low FODMAP. So that is the biggest difference between low fermentation and low FODMAP, which I think is very important for SIBO patients to understand. There's so much information online. Before I met Dr. Rezaie, I had about 4 or 5 different food lists printed out in front of me. And between all of them, I had about 2 things to eat. It was rice and chicken. I couldn't make sense of it. So I'm incredibly grateful to have met, the great doctors at the MAST program and Dr. Pimentel and Ali. They've really figured something out here, and I am proof that you can be SIBO free.
Sure. I'm going to get you, Dr. Rezaie, to expand on the macronutrients there, but it's counter, a lot of IBS patients or IBD patients, you give them the fermented food, you give them things like kefir or sauerkraut, you give them tempo, miso. These patients just empirically often do well, probiotics, some glutamine, IgG, that combination of therapies, and these patients do well, except for the patients that don't do well, that possibly their, symptoms get exacerbated. You're giving them fermented food, and this probably causes issues. So maybe expand a little bit on the macronutrients of the carbohydrates, proteins, and fats.
Yeah, absolutely. I mean, it's very important. So first of all, the diet, the tricky thing about diet is that, first of all, it's very hard to study diets. The reason why is that it's very hard to blind patients. And without blinding to see the exact effect is very hard. So that's why the anecdote comes into play. So there is no question that there are some patients that improve significantly with fermented food and all that. But the most important thing is that one main thing that I wanted to differentiate is that we generally suggest not to have fermentable food, and fermented food actually generally are accepted. Fermentable food are the food that bacteria, it just becomes the fuel for the bacteria. They just go in there. I was like, oh, thanks for the meal. So, and now you're somebody with a small intestinal bacterial overgrowth. I was like, okay, now I'm going to have a party in the small bowel. So, because now you have fed them food. And what is the most fermentable food that we eat? Carbohydrates. So the sugars that we take, and also sugar alcohols. Sugar alcohols are, for example, are the sweeteners that we use in the food. So because they're extremely sweet and they don't get necessarily absorbed by us, but bacteria are well capable of breaking down sugar alcohols. And these are the most common sweeteners that we use. And those are the ones that can cause significant amount of bloating and accentuation of SIBO symptoms. Obviously, the other fermentable, non-fermentable foods are beans, or the cabbage, and all that. But the advantage of this diet is that it gives you a happy medium in between. It's easy for me to tell the SIBO patients, well, go out there, eat chicken and white rice, and you're going to feel better. I was like, well, thanks. How can I live like that, right? So you need a low fermentation eating strategy to kind of like help yourself and eventually get yourself out to a normal diet. And that's essentially what's missing. Another important thing in low fermentation eating is the concept of meal spacing. Because remember the microbiome motor complex that I was talking about? They don't happen when we're eating. They only happen when we're in the fasting phase. So if you space your meals, then you have a higher chance of getting those microbiome complexes and help your bowels, even though they are weak in the setting of small intestinal bacterial overgrowth. So if you graze throughout the day, that's the worst thing you can do to a SIBO. So, which is interesting, is somebody with gastroparesis, for example, that's my recommendation. I was like, oh, don't eat a huge meal and eat graze throughout. And that's the problem that we have with a lot of GI disorders, that we give different dietary advice to different diseases, and rightfully so. But if you have something else, then you're going to get 100 times worse. And that's the problem. That's, for example, sometimes you see one patient on kefir is doing fantastic, and another patient is doing not that fantastic. And it's probably that's a patient with abnormal microbiome of the small bowel that you're not doing well with kefir, because so you just gave it a combination of pre and probiotics in the small bowel. So obviously that patient is not going to do well, but other patients will do well, right? So for example, patients with IBD, it's a known fact that they do well with a specific carbohydrate diet, right? So a lot of them are try that. But if you try that, for example, in as many as sort of Sibo patients, they don't do well. And that's where we are coming in saying that, hey, each disease needs its own diet and dietary sort of modifications, rather than trying to find one diet that works for every IBS patients, for example. I mean, that's not going to happen. So you have to kind of like modify it.
And maybe SIBO's increased because of erythritol, stevia, all these, sugar alcohols, and, that have been rampant. It's fascinating to hear, but I hopefully we've got a bit more time. I could carry on for hours, but I do want to talk about treatment, rifaximin, talk about the drugs, and talk about maybe start with the herbals, because a lot of people out there want to start with the herbal antibiotics. I think there's some recent research. I had Dr. William Davis, who wrote the Super Gut, and on the show, and we're going to be posting his new book as well. But tell us about the research on the herbal antibiotics.
Oh, yeah, absolutely. So, I mean, just quickly on that. So the management of bacterial overgrowth has 3 pillars. Number 1, finding if you have a modifiable underlying cause. For example, if you're narcotics, trying to get you off of narcotics to help the bowel. Number 2, induction of remission, suppressing the bacteria. Number 3, maintenance of remission. So induction of remission can be done with antibiotics or elemental diet, and antibiotics essentially break down into 2 categories: synthetic antibiotics and herbal antibiotics. And herbal antibiotics are very helpful as well for patients who are willing to take them and have access to them. So stepping back, the plants out there, they have to fight with bacteria and viruses and all the microorganisms. It's not that they're just sitting there and doing nothing. So they do produce these antibiotics that we can leverage to our health. Now, I'm not going to go into the details of what you need to take and what you have to do. That's by itself is a whole talk, and we need a functional doctor, a naturopathic doctor on our side to, at the end of the day, I'm a Western trained doctor. So if I'm talking about herbal antibiotics, we need to confirm that with a naturopathic doctor. But definitely garlic extracts like allicin has been shown to have antibiotic properties. Neem has been shown to have antibiotic properties. Oregano has been shown to have antibiotic properties. And very commonly, naturopathic doctors, they do a combination of these herbal antibiotics, usually for about 4 weeks, to suppress the amount of bacteria. And we have actually good results showing that looks like it's actually their effects actually as comparable to actually synthetic antibiotics, which honestly to me is not surprising, which is fascinating to me. And all we need to do is to do formal research just to make sure that we're not missing like the drug-to-drug interaction or long-term side effects. And these are very viable options for a treatment. And then on the other side, there are synthetic antibiotics, which are like hundreds of them out there. But the one that we like to use is rifaximin. The reason why is poorly absorbable. 99.6% of the rifaximin remains in the gut and doesn't get absorbed. Nobody wants to take antibiotics, but at least if you have to take it, we want to take something that has the least amount of systemic side effects, right? So non-absorbable and poorly absorbable antibiotics are definitely the way to go for management of Sibo, because why would I put the antibiotic in the bloodstream if I only want to target the gut? So that's the main key. Another way to induce remission is the elemental diet that Krystyna actually chose to do, is that we did, and it helped her immensely. And these are diets that are broken into the most basic pieces, meaning monosaccharides and disaccharides and fatty acids, and also the amino acids. So they don't need digestion. So everything gets digested in the first 2 or 3 feet of small bowel. And that resets the rest of the gut because they don't get any food and nutrients, and the bacteria suppresses and dies. So that's the problem with elemental diets, is that they taste really foul. And it needs a lot of commitment. Not many people have the commitment of Krystyna. She's our hero here, but to go through the elemental diet to induce that. Then you enter the maintenance phase, which is low fermentation eating, which is actually a lifestyle rather than just a diet, is the key to keep things suppressed in terms of bacteria coming back with meal spacing and the food that are less fermentable, so your body can recover and heal. Sometimes we use pro-motility drugs to help the movement of the gut, to push things forward. And that's a research that we're really active in to help patients with adjunct therapies. Because, whenever there is the disease, there is a spectrum. There's mild, moderate, and severe. So those severe cases, you need something on top to help those patients.
Great. I know we're coming to the end of the show. Maybe just one more comment from you, Dr. Ali, about gluten. Obviously, leaky gut is a name that's been thrown around there. If people go on this low fermentation diet, and obviously our gluten has been detrimentally affected with glyphosate, that's another whole show, and possibly we can have you back on, because there's just so much information here. I'm desperate to get these books out to Africa. I don't know, to advertise them as best as I can, to speak. I'm part of the South African Society of Integrative Medical Practitioners, to try and get them on that there. Possibly you guys can even do a webinar or something like that. I think that would be incredible. I'll speak to the secretary there. But tell us about 1 or 2 myths, and tell us about gluten, because something that I really take a lot of my patients off or limited is gluten. If people take this flour and then after 6 months' time, they don't have Sibo, but now they've got IBS, it can be problematic.
Yes, exactly. So just low fermentation eating is not gluten-free. So just to mention that. And there is no question that gluten in patients with gluten sensitivity, and also celiac patients, obviously, it can cause problems. Interesting enough, we did a recent research, and the only diet that was associated with elevated inflammation was actually gluten-containing diet. Which was not surprising again. So there is no question in my mind that gluten-free diet in inflammatory states is definitely going to be helpful. And that takes me back to the main point, that every disease in the GI needs its own specific diet. And we can't just go around and say that, hey, everybody has to go on low fermentation eating. No, that's not true. Or everybody has to go on gluten-free diet. Not necessarily. But you mentioned the leaky gut, increased permeability of gut mucosa, and that's no question that's a role in IBS. And there has been a recent study has been done that was published in Gut, that they showed that a lot of patients with post-infectious IBS do have objective increased gut permeability that actually in that study actually improved with glutamine. And that's a known fact. Again, I know that many people don't believe in leaky gut. I mean, in my mind, we see it. We do see it under a microscopy of the small bowel. We do see it under endomicroscopies, and it's just there. No question, it's part of the disease, and it's part of the interaction of the gut microbiome, immune system, and our health.
Brilliant. Last message of hope coming from Krystyna first, and then just from Dr. Ali. Give a message of hope to people that are suffering with this, this gut that has caused so many issues. We didn't even get to the vagus nerve and cervicovagopathies and vagal. But we'll possibly do another show, because I think this is a watershed book and a watershed cookbook that's going to help millions of people. But give us a message of hope, Krystyna.
Oh, thank you. I know how isolating this could be. So I just want to tell people that if you're struggling and frustrated and just can't figure it out, please stick with it. And I promise that that you will figure it out. Just don't give up. Advocating for your own health is the most important thing that I've learned in this process. And one of my goals for writing the book was to share the information that I gathered. So I really hope that it will help you and you won't be isolated for long.
Brilliant. Dr. Ali?
Oh, I get to give another message, huh?
You give a message of hope. You give a message of what you're seeing, because what I'm seeing in life is people's gut health is getting worse and worse, from children having issues, allergies, pain, discomfort. It just seems pernicious. And so give us a message of hope that people can hold on to.
Absolutely. I mean, the main message is that you're not alone. There was actually a survey that was done that showed that patients with IBS don't seek medical help for two reasons. Number one is that they're told that there's nothing to be done, and number two, that they're going to say that it's in your head and give you antidepressants and go home. None of those are neither of those are true anymore. So there is help out there, and without taking medications that have systemic side effects, you can help yourself and get back to your usual self.
Brilliant. Thank you so much for your time. I declare favor and blessing over you, Krystyna. I declare favor and blessing over you, Dr. Ali. It's true health pioneers like you that we look up to, that have taken a lot of time, a lot of energy, a lot of resources to write these books. The entrepreneur with the physician, with the researcher. It's inspiring in these times. And so thank you so much. I look forward to connecting, hopefully, once I've got the podcast out and the South African Society of Integrative Medicine, possibly they can listen to it, look at the book, and then we can get you on there probably with some webinar, with some slides. Dr. Ali, I think that would be great. Obviously, Krystyna, if you want to come on and promote your book, that's incredible. But thank you so much.